last instance, it was the day after the 4th of July at 9 a.m. I thought there's not going to be anybody here, so no real, didn't mind committing to it, but it's really nice to see such a crowd and hear the work you all are doing. So it sounds like we've sufficiently hyped PACE. How many of you all have heard of PACE prior to, so a few of you? Anybody from another state where they actually have PACE? Okay. So Turner West, I'm Vice President for Health Policy and Strategy at Bluegrass Care Navigators. I've been there for 16 years in a variety of roles, so pretty much my entire professional career has been spent in the hospice palliative space. So today I plan on talking about our community-based palliative care program, our home-based primary care program, and PACE. But in the interest of time, I'm going to start with PACE, since it's just based on the work that you are doing, I think that's probably where you've got the most interest. And because PACE is new, and then if we have time, we can talk about palliative care in the community space and home primary, if that sounds good. Everybody good? Cool. All right, I'll try. Oh, and I put my contact information up here. If you want to contact me, please feel free to do so anytime about anything related to frail older adults, serious illness care, end-of-life care. We'd love to talk about it. So, Bluegrass Care Navigators, I assume you all are relatively familiar with our organization. We've brought a whole team over here, so you all know I know they know how to talk about us quite well. But for just real quick, in case you don't know, Bluegrass Care Navigators, we were Hospice of the Bluegrass. We started in 1978 as essentially a group of volunteers that were committed in this community to improving the lived experience of the dying person. This was pre-Medicare hospice benefits, so it was all volunteers and dependent on philanthropy and that sort of type of support for sustaining the organization, and has grown over time. We have tremendous hospice care in Kentucky, very unique. The whole state is served by 22 not-for-profit, community-based organizations. Hospice care in Kentucky is nationally recognized. You go to some other states, hospice care doesn't look as fantastic as it does in this particular state, so we're lucky to have the providers and the individuals committed to that work here. Over the last 40 years, we've really evolved our programs and services, trying to build off that interdisciplinary kind of workforce and around-the-clock infrastructure to serve new populations. And so we've developed a number of non-hospice service lines that we feel like are responsive to patients and families in our community and to our community healthcare partners. And I can talk about any of those if you want, but that's essentially us. We have these cool slides now. Thank you all for what you've done here. So if you want to learn any more about that, we can. So I will jump right into PACE. So for folks, there were a handful of hands of people who said they'd heard of PACE. What do you know about it, or what have you heard about it? Please.
It's from the Unlock program in California is where it started, and it stands for Programs of All-Inclusive Care for the Elderly. And so it's a one-stop shop essentially where people can get physical therapy, their physician can be there, they can get home care from there. It's just everything they need, meals.
That's a fantastic answer. And you went Unlock on us, which is great. So that's the first PACE program in the United States, started in California. Outstanding. Others? Any other folks who raised your hands? All right. Well, so that was actually fantastic and very helpful. So I like to frame all of my conversations about PACE with this particular slide. So this was a survey of individuals at senior citizen centers and assisted living facilities, and we excluded individuals who had dementia. Your number 357, asked to rank what is most important. Number one, I don't think it probably comes as a shock to anybody in this room, is independence. More than pain and symptom relief, more than staying alive for as long as possible. What matters most to that person is independence in many cases. And the kind of philosophical underpinning of the PACE program is that is try to foster the independence of the frail older adult as long as possible and keep them in a community setting, provided that's what's important to them, for as long as possible. And so you'll see how the PACE program is financed and structured really towards that end. So I'm not going to bore you with the history, but as you just pointed out, Unlock, PACE started in the early 70s out in California, in San Francisco. Really, there at Unlock, they felt the traditional medical model did not meet the needs of the frail older adult or the person who was losing independence slowly over time, and that seniors wanted to age at home but needed services to maintain that independence. This goes on for about 20 years. It's funny how much it mirrors kind of the history of hospice care in the United States, and that it's this grassroots movement that eventually gets the attention of CMS. I mean, it would be HIPAA at the time, but it gets the attention of CMS for how do we finance to pay for this and scale it in a way that we can reach more individuals. So you see these kind of testing of what the PACE model does in terms of quality, in terms of cost, back in the early 80s. In the mid-'80s, you've got federal legislation that extends this finance delivery system, allowing for 10 additional organizations to replicate the OnLock site. And then you've seen this slow expansion of PACE across the United States. You can see now across the United States, there are 134 PACE organizations. And I think PACE, Kentucky is now gonna be the 33rd state. Indiana was the last state to authorize PACE, now it's Kentucky. And it serves about 50,000 individuals across the US. So a relatively small but incredibly impactful program for a very specified patient population, which we'll discuss in more detail. So any questions, comments on that? Bored yet? Yeah, give me some time, give me a little bit of time, we'll get there. Eligibility for the program. All right, so PACE is to enroll in a PACE program, and a person has to be 55 years or older. They have to live in the service area of a PACE organization. I'll show you the service area that we have for our particular PACE program. They have to be certified by the state in which the person lives as meeting the need for nursing home level of care. And they have to be able to live safely in the community with the help of a PACE services at the time of enrollment into the PACE program. Does all that follow? So think about, and again, if you just need a picture of it, I'll give you some examples of what this looks like in practice, but think frail older adult, struggling to retain independence, who wants to stay in a community setting and is able to with the right services and supports in the community setting. Okay? 55 and older. So in terms of what is PACE, I like to think of PACE, you did such a nice job describing it, I really appreciate it. It's a unique model of managed care service delivery for frail elders. In practice, most of these folks are dually eligible for Medicare and Medicaid. I mean, it's like 97% of PACE enrollees are dually eligible. And all of whom are assessed as being eligible for nursing home placement according to the Medicaid standards established by their state. Think of PACE as both a model of healthcare delivery, which we'll talk about the healthcare model, the model component in a moment, and kind of as an insurance product. It is like a managed care plan. From CMS's perspective, PACE is just like a Medicare Advantage plan. From the Medicaid, on the state side, you're getting a capitated payment every month to cover all of the healthcare related needs that a particular person has, all their Medicare and Medicaid benefits. So think of it as a model of healthcare delivery and kind of an insurance product. And I've already mentioned here that the philosophical underpinning is the belief that it is better for the well-being of the senior with chronic care needs and their families to be served in the community whenever possible. Finally here, just kind of going back to this point, PACE organization, so Bluegrass Care Navigators, as a PACE organization, will be a provider of healthcare services. There are certain things where our employees are going to provide care, like primary care services. We'll have an interdisciplinary team, nursing assistants, social workers, chaplains, nurses, so on and so forth. But we're also a payer for healthcare services. So we are contracting with reputable hospitals, specialists, nursing homes, assisted living facilities. We have our own network because for us as the PACE organization, we're providing certain types of healthcare and we are paying for other types of healthcare. Again, based on what matters to that specific individual enrolled in the PACE program. What's their current condition? What matters most to that person? That sort of thing. Let me pause. Does that follow for everybody? What questions do you have just based on that?
I hate to be the one to ask.
Please.
Help me out, Turk.
Yeah.
Is this based on certificate of need, or how many PACE organizations can you have in a state?
It's up to every state to define the number of PACE organizations that it will allow. Typically, because PACE is a small program, and there's a lot of capital infrastructure that a PACE organization has to take on a lot of financial risk. There are financial risk for the spend of the participants enrolled in the program, but also up front, you have to invest in a PACE center, which I'll describe momentarily, and that can be up to $1 million. So typically, it's limited to one PACE organization per service area. In some cases, if you get into a really large county, you might be able to have two financially viable PACE organizations, but because of the small number and the financial risk, they're not, like Lexington, Fayette County could not support in a financially sustainable way two PACE organizations. So there's just not enough number of frail older adults who would be eligible for services. Yes, and then yes. Please.
So how many participants, patients, whatever, can a PACE organization serve?
So some states will cap how many individuals that will allow to enroll in PACE, others don't. It really is just kind of conditional on the demographics of a particular county. So
do you know any of those demographics for here?
We do, and so like in in Fayette County, you know, we think that 5 years out, we would be serving around 400 individuals in our PACE program. You know, we estimate a growth rate, just looking at what happens nationally, of about 5 participants per month. So it's a slow, gradual growth of your program. And most people, PACE has very low disenrollment rates. So most people enroll in PACE are there through the end of their lives, which can be 15, 20 years in some instances, if that makes sense. So if you think about that, I'm sorry, go ahead, please. I'm sorry.
I was wondering how this interfaces with the Medicaid waiver program. It seems like the criteria to qualify is similar.
It is similar. So, but you know, when a person enrolls in PACE, it's interesting because I don't know the answer directly in terms of what the interaction is with certain Medicaid waivers, and there are many people in the room who know way more about this space than I do. But I know as the PACE organization, it will be our responsibility to provide for the healthcare, the social needs of that particular person, and we be incentivized to think about what is the best care possible for this particular person based on their health conditions and what matters to them. It's a great question. Yes, please.
There's no cost to them, correct?
There is no cost to them except for the state is still hammering out certain patient liabilities and instances where there's nursing home placement, but not fully done yet. Please.
Would this replace VA benefits, or would it be in addition to, or how would that, if a veteran signed up for it, could they?
So again, it's a good question. I don't think a person who receives their benefits from the VA can enroll in PACE. So I think these are, you know, you have to have Medicare Part A and Part B, and then again, in practice, in theory, a person could just be Medicare only and then pay the Medicaid capitated rate to enroll in PACE, which some people do if they're on like a spend down trajectory. But in practice, most of these folks are just dually eligible. And I know I think the VA with their, what is it called? Their long-term care, geriatrics, got a nice.
Aid and attendance?
Well, their division that focuses on long-term care and geriatrics. I know they talked about PACE-like models for, you know, their veterans. So, great question, Joel. Really good stuff. So just going back here, if you look at the eligibility for PACE, so if we look at this, you know, we can drill down and estimate how many people in Fayette County would meet this criteria. And then it tends to be around 5 to 10% of that number that enroll in a PACE program. So it's about 5 to 10% of people who are eligible, in theory, you know. Okay. So, yeah, here we go. Let's just keep on going with PACE. So when a person enrolls in PACE, they agree to forego their usual source of care and receive all services through the PACE organization, where the PACE organization is doing essentially the care coordination, and they're agreeing to the network that the PACE organization has developed. The PACE organization must cover all Medicare and Medicaid covered services. The PACE organization assumes full financial risk without limits on amount, duration, scope of services, and the PACE services are guided by an interdisciplinary team that regularly assesses the needs of the participant, coordinates service delivery, and reviews and updates a plan of care. So I'll talk a little more about that in a minute. I've already alluded to some of this, but you can see kind of the perennial growth in PACE over time. 95, despite this being a patient population that it meets the nursing home level of care in their respective states, 95% are able to live in the community space. Doesn't mean that they all do, right? So sometimes, we will be contracting with assisted living facilities and nursing homes. So if a person can't live in the community space, the PACE organization can't disenroll somebody because they're worried they're going to get too expensive, or they need nursing home placement, or they need to go into an assisted living facility. Once they're in, you know, unless the participant wants to disenroll, or there's some sort of situation where it wouldn't be safe to provide care for the person. So I like this visual here. I've been using a visual like this my entire life working in hospice care. So we have interdisciplinary care is endemic to what we've been doing for the last 40 years. So it ports over nicely to PACE. You can see our PACE interdisciplinary team here. These are individuals we are hiring, and these are our employees that are supporting our PACE participants. In addition to the interdisciplinary team, as I mentioned, we have to cover all Medicare and Medicaid benefits, so we cover our network. I think, as this group probably knows, the Medicare program wasn't exactly designed well to care for large numbers of individuals who are living with serious illness, or large number of individuals who are dealing with frailty. So this moves us away from that kind of fee-for-service reimbursement system that I think is oftentimes not aligned with what a particular person needs. So this kind of capitated amount that we receive from Medicare and Medicaid gives us the flexibility to tailor our services to the needs of our individual patients. So we can invest in those social determinants of health type, create that infrastructure that we all know is oftentimes so lacking or done on donations or things like that. We can invest in meals, we can invest in home modifications and dental care and socialization. We can, really make those programs meaningful and scalable for this particular patient population because there's the right kind of clinical and financial incentives, which is oftentimes lacking in our more traditional fee-for-service type of environment. Any questions or comments about this?
What,
Sorry, go ahead.
what does SDOH stand
Social
for?
determinants of health, sorry.
What?
Social determinants of health.
Oh,
I should've
okay.
just spelled that
That's-
out, sorry, Will. Yes, sir.
What are so the financial on the prior slide was that you guys take the full financial risk, so if the costs get out of hand, it's on you guys.
Correct, so let's take something like an avoidable hospitalization that's the result of, say, there's no incentive to make sure that the home, that we're mitigating the likelihood of a fall in the home. That person falls, they go to the hospital, we're on the hook for that $14,000, $15,000 bill for the hospitalization. Now we have, since we would be paying that if that happens, we were really even further incentivized to look at the home setting. Is it safe? Is Mrs. Smith, does she look a little bit different today than she did yesterday? Because we just saw her in the Pace Center yesterday, and she seemed to be doing just fine and playing cards with her friends, and today she looks different or worse, or whatever the case may be. That we have extra attention. Maybe we want to send a nurse out. Maybe we want to send a nursing assistant out on Saturday because that $50 is a lot cheaper than if she's running off to the emergency department or getting hospitalized. So you have that investment. But yes, to your point, if they get expensive, so they go to the hospital, we're paying the hospital every time. They go to the emergency department, in a nursing home, assisted living, it doesn't matter. We are on the hook for all of their healthcare expenditures.
So the full suite of services that you're able to bill for, you're hoping the overhead will be covered.
Right, and so in PACE, we're not really billing anyone for anything. We will get a fixed amount of money per month from Medicare on the federal side and a fixed amount of money per month from Medicaid on the state side. And then we get a Part D payment from Medicare because we're covering their medications that actually turns out to just kind of be a wash. But through that capitated amount of money, that's what you get. And you're on the hook for paying for all the healthcare services. So it's in your team's best interest to figure out what matters most to this person. Let's develop a plan of care based on their goals, and then we're gonna work collaboratively with all of us, bring our interdisciplinary expertise to help that particular person achieve any goals that are identified. And one of the goals that oftentimes we hear from patients who are enrolled in a PACE program are independence, staying in my home, avoiding the hospital, that sort of thing. And so how do we make that happen? It also aligns with us financially. Paying for an avoidable hospitalization, you're not gonna run a very successful PACE program if you have too many of those. So, great questions, Ron. What else? Thoughts, comments? Yes, please.
I can think of hundreds of people who qualify.
Good.
You'll follow our course, though. How will you screen to determine who gets accepted?
So,
Maybe that's further on here.
yeah, well, I will, so if they meet the eligibility criteria for PACE and they want to be in the program, they're going to be in the program. So we can't, cherry pick or skim and be like, well, we want a healthy, we really like somebody who's 57, looks like they got 30 good years left in them. We can't do that. So the way it will work, and we will really get outside of my depth quickly on this, is there a clock system? You all know this clock system? Kentucky level of care, something like that. So we're working out how our team will screen whether a person is eligible for Medicaid and meets the state's criteria for nursing home level of care, and then the state, I think, will essentially validate that on the back end.
Have you guys done an impact on small businesses that already provide these services?
Well, so on which parts, sir? So some of this stuff, you know, PACE is unique. I don't know, there are certain parts that, certain services that a PACE participant may receive that, you know, currently exist, but I think, you know, we would be paying for some of those things.
Cause I see a lot of small businesses right in there.
Yeah, so for example, we are contracting with occupational therapists, we're hiring a recreational therapist, physical therapy. So we, you know, we are going to be good partners and good payers for many other, you know, for our nursing home partners, for our assisted living partners, that sort of thing, so. Don't see it too much as a replacement per se for some of those other service lines. Yes, please, Gina.
My question is with like physical therapy for people who are aging, a lot of times when they go in the nursing home, they only get a certain amount of time, like 10, 15, 20, and then they get clocked out. Is this ongoing? Can they continually get it if it continues to build their strength at some point?
Absolutely, yep. Be very much needs driven, based on what.
Needs driven. That's very good.
Yeah,
because
hi,
that-
Gina, by the way.
Hi.
It's good to see you. All right. You left us, that's okay. Yes, please.
Do you have, like an advisory panel as you're creating this?
We do, so we have to have representation for the PACE population on our larger board of directors. And then as we get the program going, we will have an advisory body. There's a gerontologist, kind of researcher, health policy person named Joanne Lynn. I don't know if anybody's familiar with Joanne Lynn. Joanne Lynn wrote a book called Medicare in Communities. So she's like, if we're gonna fix the Medicare program, part of the way to do that is to replicate the PACE type model. And she talked about having these community advisory boards for PACE, and I very much want to try to replicate, and she calls it something different that I can't remember. But yes, we're very much interested in doing something like that. It's just, it's been such a Herculean lift to get to this point. We'll eventually get there.
I have a question for you as well, Pam, about the eligibility. How long, say for instance, I know somebody that meets all the criteria there. How do they apply for it? And how long do they have to wait to get approved for it?
Yeah, so because, as I mentioned, PACE from like CMS's perspective is like a Medicare Advantage plan, you can only enroll on the first of every month. So there will be a process that we'll have internally. We'll have an intake kind of coordinator that will essentially screen the person to say, you know, are you eligible for Medicaid? Do you meet the nursing home level of care? Do you understand what it means to enroll in PACE, the requisite paperwork, that sort of stuff? And then you would get that person set up, assuming all the boxes are checked, to enroll in the first of the following month. So, if that did answer your question. Okay.
I just want to clarify one thing. The nursing home and assisted living, you can't start the program being in one of those. You go to those if need be down the road. So we're not going to be enrolling people that are currently in a nursing home.
Correct.
Assisted living.
That's, yeah, correct.
So when does it start? When does the program actually start?
It's a great question. So
What day, hour, and minute?
Yeah.
Is gonna be born?
Very proud.
It's been depending on how you want to count. PACE has been a conversation in Kentucky, as far as I can know, going back to the early 90s. We've been having conversations with the state about PACE 5 years, at least 5 years, where we've had introductory conversations about PACE. So it is a complicated application process that results in a three-way agreement between the federal government, state government, and the PACE organization. So we have that signed from the state. We've signed it, state signed it, waiting on CMS to sign it. They've approved the application, so it's just a matter of time. But assuming that gets done in the next few weeks, August 1 will be when we enroll our first participant, hopefully. Yes. Let's wait and see.
Hurry up and wait.
Yes. Yes,
For
please.
comparison, Humana Advantage Plan versus PACE Advantage Plan, is that apples to apples, oranges to oranges, or not?
Well, you know, I wouldn't say they're apples to apples. It's a really great question. How it, so I would think about a D-SNP or something, one of those Humana plans. I think they're a little bit different. I could answer this question better than I'm doing right now. You know,
Provide the ongoing physical therapy.
Yeah,
And the
yeah.
driver, and, you know, those.
So one, you'll see with the PACE Center, how that's designed to maximize, designed to be responsive to some of the needs of the frail older adult. I'm just trying to think how to tackle it, because increasingly, as I do work for a health plan,
that plan, I'm just.
Oh, okay.
curious.
Okay, well. Okay, sorry, well, I was just thinking, increasingly the Medicare Advantage space, there's more flexibilities for health plans to invest in some of these meal deliveries, home modifications, send volunteers, all that sort of thing. I think in practice, it's not really happening, and I don't think your Medicare Advantage plan, Humana is gonna know you as well as your PACE organization is gonna know you. So the Humana Advantage plan is not gonna be seeing the PACE participant every day, know that particular person, be sending their team members. And, Humana is primarily a payer, they're a provider in some instances, but here you have that fusion of being both a payer and provider, so you know the person incredibly well in a way I think a large plan like Humana, no matter how terrific their case managers are gonna be, you're not gonna know the person.
I think what else is unique about PACE is that the participant is the driver in this.
Yeah.
They really are the ones that come with their asks and their needs and their wants, and we focus on addressing those. It's not the other way around, where we have sort of this template that we get people into. It's really individually geared towards the participant front and center.
I think that's absolutely right, and having that flexibility to really do that individualized, tailored approach for every person I think it's going to be something that's exciting for our organization to do.
I'm sorry, I'm confused. So, do they pay for it like an insurance plan?
They do.
Okay.
When you say they, you mean?
The individual, the participant?
The participant is not going to be paying for it as they would. There's no premium associated with PACE the way there may be in some Medicare Advantage plans. We will get paid.
Because you're talking about Anthem and Humana, and I'm like, okay, well, they pay monthly for that, et cetera, et cetera.
They won't be paying for anything like that, no.
So they have to how do they qualify for a non-payment oriented insurance like this?
So in the PACE world so in the Medicare Advantage world, you have some plans where there's gonna be a monthly premium or cost sharing and other plans that you don't. In the PACE world, because this is again, primarily almost exclusively dually eligible individuals, there is no premium, there's no cost sharing, except in one instance that the state's still hammering out. In terms of how we would get paid as a PACE organization, it'd be much like an insurance plan is paid from CMS. We'll get a fixed amount of money per month based on the acuity level of the PACE participant. Somewhat just like Humana is gonna get, for every person enrolled, they're gonna get $1,000 per month. We'll get, paid like that in a capitated way. Please.
So do you assume their, premium that they're charged monthly for Medicare?
That's a great question. Yes.
So it's like an Advantage plan?
It is like an Advantage
You
plan,
become
yes.
their Medicare provider?
Yeah.
That makes
And we have to
sense.
cover all Medicare services. Again, we can't just say, hey, every person that enrolls in PACE is full access to all the benefits that they would have under Medicare and Medicaid. So there's no loss. For a PACE participant, you have to think about, do I want to get all of my PACE or all of my benefits coordinated through the PACE organization? So you guys am I comfortable with the PACE doc being my primary care doc, and am I comfortable with using their network that they've developed? So that's really kind of the trade-off for the PACE participant.
So they don't get choice in provider. They get you as the provider.
It's in practice, they will have to select the PACE primary care doc as their primary care doctor. However, if they had a strong allegiance to a particular primary care doctor, we would contract with that physician or may contract with that physician. But then again, one of the reasons we'd have to figure out a way for that physician to be contributing to the plan of care and kind of be a part of the interdisciplinary approach that we're taking with our participants. Please.
I'm assuming there's a financial cap, if they have to be Medicare and Medicaid, right? I mean, to get.
Correct. Well, by financial cap, you mean?
I'm not sure what I mean by it.
Okay.
No, but I feel like
The-
what you're
the
saying is true,
individual-
yeah.
So,
The participant can't have an income higher than a certain level, is that what you're saying?
That's what I'm wondering, or assets, you know what I mean?
Right,
Because
right.
as you get older, sometimes you don't have the income.
Right.
correct, and again,
Person
they'll
speaking
have
of
to,
him.
yes.
So, but assets, do you have to have a cap, That's
So,
what-
yes and no. So in practice, again, about 98% are dually eligible, so they've qualified for Medicaid. You could have someone who's Medicare only that has the means and resources to pay the Medicaid capitated amount, which is around $4,000, I don't know exactly, $4,000 a month. So there are very few individuals who have those resources that are gonna wanna enroll in a PACE program.
Okay.
So great question, please.
you may have that as we go on, the pictures of the facility, do you have
I
anything?
did, I don't know if I put any in here.
Cause that, to me, kind of set the tone for a lot of things. I don't wanna steal your thunder.
No, you're not stealing anything.
I did go to
I think what we'll do is, I'll send out on the list of the open house dates.
Okay,
We did sort
I
of a
went
limited-
to the facility, and some of you all that have been in healthcare, the facility actually was hospice facility, which to me was kind of interesting in itself, because you go down those chutes, and then there was that in-service area and stuff like that, and I don't know how they turned that facility into something the size of Rubber Arena, because that's what it looks like now. I mean, it's huge, and it's beautiful. And so when Turner was talking about this all-inclusive, actually seeing that and walking through that, it was like, wow. I mean, there's quiet areas, there's extra quiet areas, there's small group sessions, there's big places, there's laundry facilities, there's these huge walk-in shower areas, and primary care provider came up as well, and so I'm like, wow. Of course, you know, I'm from the UK, well, got years of, maybe I probably shouldn't say that, decades of experience. I don't know how that is.
Kind of our age range.
Oh, yeah, I have decades of healthcare experience. No, but the rooms in this clinic are massive, the patient rooms, and I think you had 4 patient rooms or something in this clinic, and so it's not, just like someplace that somebody can come every day, but I guess they can come 5 days a week if they want to, if they're rather more comfortable at home and only wanna come there once a day. There's drivers, transportation's provided to that facility, but, you know, I work a lot with our senior patients at UK, and we get these, folks that come into the emergency department, they're treated, and it's like they need this, 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 and this, and they go home, and they either haven't picked up their medicine, which is an easy fix, or they don't understand and they don't take it, and so that continuity, and as I talked to the provider there at PACE, it's like, I was concerned people would be unenrolled because the compliance and the follow-through would make such a huge difference on that patient, their health would improve. You know, the physical therapy area that's accessible to them all the time. The question came up about physical therapy, I think Gina, you asked that, but it's like a physical therapy room. And so if you've got somebody being monitored like that, and they were saying, you know, if a nurse needs to call them at 9 o'clock at night and say, Katie, did you take that medicine? I know, you know, then that happens. And so that whole follow through is so different than anything we've got going on in this area. It was just unbelievable to me. But, you know, everything from, you said something about the open house, this industrial, I don't know what it's called, industrial kitchen, and I mean, it just goes on and on and on. And I don't work for Bluegrass
You want my job, Ken?
But I came away from that, well, my first thought was, oh, I wanna be part of this, and I was like, wait a minute, I really don't wanna be yet, hold on for just a minute. But, I think that's where it's like, segments of that we all do, and we all know where we can go, and we can send patients and clients, and we provide those pieces, but this kind of one-stop shop, is really unbelievable, but I
Yeah,
I'll hush.
no, please, that was great, thank you. Andy, so Hazel, you'll send the dates for the open house. We have 2 more, I hope all of you can come by, at least take a quick guided tour through there. We have our physicians, nurses, social workers, dietitian, I think our recreational therapists, all there to talk a little bit about what they will be doing. But you'll get a view of the PACE Center, which is kind of the locus of the PACE model. So let me pick up my pace a little bit, because I know we're getting short on time. I want to give you kind of a sense for what the PACE participant looks like in practice. So we have kind of this idea of the eligibility we've already talked about. In practice, the average is national numbers, average age 77. You can see that while it's for 55 and older, in practice most are over the age of 65, disproportionately female. And you can see in terms of frailty, about a third need assistance with 5 to 6 ADLs, 24% 3 to 4, 26% 1 to 2. In terms of the top 5 chronic conditions, on average, a PACE participant has 5.8 chronic conditions. You can see the most common here. In an average month, 6 prescriptions are filled, 7 visits to the PACE Center. And again, you have people who come to the PACE Center who come, every day. Some may come much less frequently. Some may just be in the only, may never come to the PACE Center, and about 46% of individuals have some form of dementia. 16 trips per month. Haven't talked a whole lot about transportation, but that's another unique feature. We know how often transportation can be a barrier for frail older adults. So it can be transportation to doctor's appointments, to get your hair done, to get to the PACE Center. We're contracting for transportation services initially, but we will be hiring a driver and buying vans, and they're really expensive now. Turns out getting cars is not free anymore. So anyway, that give you a sense of what the PACE participant looks like. At our PACE Center, we had the federal officials on site for a week and state officials to essentially survey the PACE Center. Folks who've been doing this for 10, 15 years, they said it was one of the nicest PACE Centers they've ever seen. So please tell our board of directors, donors invested in this facility. I think it looks fantastic, and it's going to be a very inviting place for individuals in our community, but it had to be designed around certain licensing requirements. And you can see here some of the things that we're required to have. So we'll have primary care services, we'll have social services, restorative therapies like PT and OT. Personal care will take place at the theater or at the center. Nutritional services, our dietitian, she was great. She seemed cool. She'd be great. Socialization and recreational therapy. Again, meals are delivered there. I hope you'll get this thing where it's like social center, social and personal care, medical clinic, and team-based. So that's not our PACE Center, but I did steal this slide, so you get what you pay for with the photo.
Where is it located?
It is Members Way. Right off Alexandria.
Oh, it's the old.
Right, yeah,
Okay.
where Hazel and I had an office and clinical.
Is it the one that's tucked away in the back?
Yeah.
Okay.
Yeah.
And it's been completely transformed. If you were ever in there, it was just like, a labyrinth of cubicles, and it's actually looks quite inviting. Okay. I already talked about the provider networks. Again, we have to make sure that we have a network that sufficiently covers all Medicare and Medicaid services, and there are, again, federal guidelines around what that has to look like. So consulting providers, inpatient and nursing facility contracts, all that sort of stuff. The value of PACE, I pulled this together for patients and families. There's extremely high satisfaction with PACE services. One way that's indicated is by incredibly low disenrollment rates. You see reduction in morbidity and mortality for PACE participants when compared to other similar cohort not enrolled in PACE. You see a reduction in that non-beneficial utilization of healthcare services, emergency department use, hospitalization, rehospitalization rates, and you see a reduction in Medicare and Medicaid spending, which is why the federal government and the state, one of the reasons why they like PACE as a model. Enhancements in quality of care, better reported health status, less pain, less depression, better preventive care, more advanced care planning. And then for Kentucky, improved patient care and emphasis on preventative care over institutional care. It's less costly for the Medicaid program. That the Medicaid rates that were paid for PACE are, so they hire actuaries to look at what they think this patient population would cost, and then they say, we're gonna cap it at 95% of whatever that number is. So you're getting something that's budget predictable, and again, at a lower cost than what you anticipate you'd spend on that patient population. And then PACE, aligns well with the overall trends we see in healthcare delivery, to shift financial risk to providers, and again, to invest in healthcare that reduces unnecessary, unwanted, and potentially harmful sources of healthcare utilization. We've talked about payment for PACE services. But again, I think that capitated payment is so important for this particular patient population because it gives the provider the flexibility to tailor the healthcare services interventions to align with the needs, goals, and preferences of the enrollee. And that's all I'll say on PACE, because I know it's later than I thought. What do you want to talk about? What questions do you have? Please.
Service area.
Service area, should have put that one in there. See, I did this Friday afternoon late. But I did it. The counties, by the way, just so you're aware, we had to go through a very lengthy application process with CMS where you have to define the counties in advance. So we can't readily expand. These are our 5 counties, which would be Fayette, Jessamine, Anderson, Franklin, and Woodford counties. 5 for 5. Early in the morning. So yes, those were did you all catch those? I should have put that in. Fayette, Jessamine, Anderson, Woodford, and Franklin. Now in Franklin County, we have an adult day healthcare center. that in the PACE world will also be used at what they call as an alternative care setting. So it'll be a place where participants can get some types of healthcare and can come for socialization, but it's not as full and robust as the PACE Center in Lexington.
So with the waiver programs, how does that cross into what waiver programs do? Cause it seems like it crosses a lot of it.
I don't know the answer to that question in terms of the interplay. My sense would be they would come out of any waivers in the PACE organization would pay for those types of services, but I'm speaking out of turn here, so I don't know.
And what about those other day centers?
In terms of?
Like, because those are participants for those day centers could go out of business.
I'm not sure about them going out of business, but in theory, they would come to the PACE Center for socialization as opposed to the day center. Good question, though.
I
Please.
just have a statement. I feel like if you all are taking 5 people per month and the wait list is like astronomical,
Well, no,
there's not gonna be any place going out of business for
Yeah,
lack of any,
yeah.
that's just my
There's
opinion.
plenty.
But
of
it never turns out to be 5 per month. It turns out to be 500 the first month, and then it turns out to be another 500 the next month.
Yeah,
It's,
well,
5 is a nice number to say, but
Yeah.
it's not true.
so, well, I would say that the 5 per month comes from national data. So we hired consultants to model out what we think enrollment would be based on how new programs start across the US. It tends to be 5 per month.
And
And
things
have
like the
some
waiver
February
program, we use home and community-based waiver, and, you know, it's non-skilled services, it's in the home, it's limited number of hours, you know, then that's not the skilled services piece of it, it's not the PT, it's not the OT, it's not medication, all of those things, so it's again pieces, but, as it was alluded to, I think there are plenty of our seniors that are needed to go around, so I think this fills an unmet need.
And you have to think too, that some of the participants aren't accessing those other services already anyway.
No, they aren't.
What?
They aren't accessing those services. It's very
Yeah.
And I think the PACE Center model clears up a lot of confusion for the participants, because as it is now, they don't understand, okay, I get non-medical help at home. What about the medical people that come in? Who do I call for them? And how do I get, wound treatment in my home? The home and community-based waiver person that I have helping me can't do that. And where do I go for PT, and who pays for that? So,
Oh, I love that.
and
Yeah.
meals, who do I call to get meals? Meals on Wheels? I mean, where do it's just so many little pieces like you all were alluding to, and so this is
Well,
great.
remember, it's 24/7, so we're responsible, we're on the clock every day.
Yeah, that's
The Consortium's
fantastic.
only open 5 days a week, we are responsible for those participants 24/7. That's a pretty nice tether.
I've been a fan of the PACE Center since I first learned about it in 2008. I was like, oh my gosh, why don't we have this? I got a Medicare booklet for my in-laws that were living with me at the time, and it talked about the PACE Center, and it said may not be available in your state. And I'm like, why not?
Well, at least we're not 50th to jump on.
And I know we're a few minutes till 10. Turner, if you don't mind, I wish you would answer a few more
I'm
questions
happy to
if you
answer any
can,
more
but.
questions. I also have my contact information up here. You can call, visit anytime, and come to the open house.
There are,
please.
but let me just say, if there's a few people that can still stay, if you need to get up and leave, I know our meeting runs till 10, and we will do announcements as well at the end. If you've got some other announcements you want to put on the listserv, you can send to Susan, but let me turn this back over to Turner to answer a few more questions.
Please.
There's a nice little infographic at the desk, and my card is there, and so is Sandy Gowdy. Sandy Gowdy is our intern, or enrollment specialist, so if you wanna grab those cards, you can.
And this chapstick.
And there's.
Please, do you know the
Oh,
two dates?
yes, I do.
Wednesday and the next Wednesday, I think.
It's Wednesday, the 29th from 3 to 5, and, that was June. It's July 13th from 3 to 5, and July 26th from 5 to 7. But I'll send it out on the list. And it says you have to RSVP, but realistically, just,
And the 13th is what time again, sorry?
what does it say on there?
Thirteenth is 3 to 5.
Okay.
The 26th is 5 to 7, correct?
I think the other thing with the numbers of participants, where you know, how many will it be? Keep in mind too, that there will be people that will utilize the center, but there'll also be lots of people that never will, and they'll be the ones we're caring for in their own home. So it's kind of a hybrid of, you know, and again, it gets to what the participant wants or what they need versus what is expected of, you know.
No, I think anything that can clear up confusion and help people when they get in a zone where it's like, what do I do? Cause I have to take care of this now, and I've been ignoring it for the last 15 years, even though I've seen this problem progress. So, I love the idea of it, you know? And then definitely having a place to send people for it to get handled. You know, cause it's not like you said,
Parsing it
it's
out all over the
everything,
place. Yeah.
PT, OT, yeah, it's crazy, so.
Very comprehensive.
Any other questions for Turner?
Just a comment, as case managers out there in the field, we're detectives trying to figure out, if you go into a home, trying to figure out if people are getting services, where are they coming from, looking for the brochures from their agencies. Are the meals delivered by an individual or by, you know, a van? And I mean, it will be wonderful for those of us who work in the community. If we know they're in pace, we'll know where everything's coming.